So, uh, if you've ever wondered why people look perpetually tired or, angry as they get older, the answer isn't just sagging skin.
Right. It's so much more than that.
Yeah, exactly. It's this microscopic, highly aggressive tug of war happening just beneath the surface. I mean, the upper face is basically a complex pulley system of fighting muscles, hidden ligaments, and these really critical nerve networks.
It really is. And, since you, our listeners, are specifically preparing for your plastic surgery board exams like the FRCS, we really need to dig into the mechanics.
Right. Our mission for this deep dive is to look completely past the purely aesthetic results. We are going to explore the intense biomechanical engineering, the anatomical tripwires, and the architectural precision required to literally alter human expression through a brow lift.
Because you really have to master the structural foundation, right? The
Yeah.
tissue planes, the surgical execute, all of it.
Absolutely.
Yeah.
And real quick, before we jump in, if you want to ace those exams, head to medsynclimited.com and get the FRCS Plastic Surgery Anki Deck with over 6,000 questions arranged by topic to help you recall the key facts.
Yeah, it's a lifesaver. It's based on the textbook Keynotes in Plastic Surgery.
So let's just get straight into it. When we talk about this area of anatomy, why is it so, I guess, so treacherous for a surgeon?
Well, it is a phenomenal area of anatomy precisely because of how densely packed the vital structures are. To safely mobilize the forehead and brow, a surgeon basically has to systematically deconstruct the architecture of the face.
Wow. Deconstruct the architecture.
Yeah, I mean, you have to understand exactly what is tethering the tissue to the bone before you can even begin to think about elevating it.
Right, which brings us right to the scaffolding of the forehead and the temporal region. Because before any elevation happens, you have to find your boundaries. Right?
Exactly. You always start with the boundaries.
So you're palpating the temporal fossa, which is separated from the forehead by the bony temporal ridge.
Yeah.
And that ridge incorporates the temporal fusion line and its superior extension.
Yes, and that is where you hit the main obstacle to movement.
The zone of fixation.
The zone of fixation, right. Examiners love this. It's this highly specific 6 millimeter wide strip of tissue located just medial to the temporal ridge.
And it's just densely glued to the bone.
Tightly glued, straight to the bone. That zone is the absolute crux of the structural release. If you do not completely release that 6 millimeter strip, I mean, the brow just will not move.
Wow, okay, so to get to it, you have to navigate the fascial layers first, right?
Right. So over most of the skull, you have the glia aponeurotica. And for board purposes, remember, this acts as the upper equivalent of the SMAS layer found in the midface.
Oh, that's a good comparison.
Yeah, and as it moves over the forehead, this glia splits to envelop the frontalis muscle, creating a superficial and a deep layer.
And then as it descends toward the brow, that deep layer gets even more complex. It splits again, right?
Exactly. It splits to wrap around the glia fat pad.
Right. And the deepest portion of that fascial layer, the part that's under the fat pad, fuses directly to the supraorbital periosteum.
Precisely. And just like that zone of fixation we talked about, that periosteal fusion is densely adherent to the underlying bone.
So they're like twin anchors.
Yeah, twin zones of extreme adherence. Both of them must be completely released to mobilize the tissue.
Visualizing this biomechanically, it's kind of like a thick carpet that has been meticulously nailed down to the floorboards.
I love that analogy.
Right, because you can't just grab the edge of the carpet and pull it to stretch it out. The tension would completely ruin the material.
Oh, exactly. It would just tear.
Yeah, you have to physically get underneath and pry up those heavy nails first if you want any true stress-free mobility.
That is the perfect mechanism to keep in mind, especially when you consider what happens laterally.
What do you mean?
Well, as you move laterally across that temporal fusion line, the glia ends, right? And the superficial temporal fascia begins. They are essentially a continuous sheet.
Okay.
But crucially, the superficial temporal fascia is heavily tethered to the overlying skin by this dense network of fibrous connections.
They're locked together.
Completely locked, which means they move as a single unified block.
Oh, I see. So the surgeon can pull on that deep fascial layer to elevate the lateral third of the brow without actually putting direct tension on the overlying skin.
Yes, and that is a massive clinical advantage because placing tension on hair-bearing skin is exactly what causes localized hair loss.
Alopecia.
Right, alopecia along the incision lines.
Yeah.
You are lifting from the foundation, not the roof.
That makes total sense.
Yeah.
So as you dissect laterally in the plane between the superficial and deep temporal fascia, the tissue just gives way easily.
It does, yeah. There is very little resistance there. But and this is a big, but you will hit a major anatomical structure about 2 to 3 centimeters superior to the zygomatic arch.
The orbicularis temporal ligament.
Right. Or the inferior temporal septum. It's a horizontal line of adhesion.
And that septum, it acts almost like a vault door, doesn't it?
That's a great way to put it. Dissecting through that specific ligament is the gateway into a highly dangerous anatomical space.
Between the septum and the zygomatic arch.
Exactly. That is where the vital structures are housed. Specifically, you've got the frontal branches of cranial nerve sheath running within the parotid temporal fascia.
Right, alongside the zygomaticotemporal vessels and nerves.
Navigating that vault door requires absolute precision because once you are through, you are essentially in the engine room.
Okay, so the nails are pried up, the fascial carpet is released, the vault is open, the tissue is free.
But it's still subject to the active engine of human expression.
Right, the muscles, they are constantly pulling on this newly freed tissue, and the entire upward movement basically relies on a single elevator, right? The frontalis muscle.
Yeah, it is an incredibly lonely battle for the frontalis. It's a paired, broad, flat muscle supplied entirely by the frontal branch of the facial nerve.
And superiorly, it's fixed to the deep galea layer just anterior to the coronal suture.
But here's the kicker. The inferior edge has no bony attachment.
None at all.
None. It simply inserts into the skin and the orbicularis oculi muscle beneath the brow, so when it contracts, it pulls the forehead skin up.
And those dermal connections cause the tissue to fold, which creates those transverse forehead lines we all get.
Exactly. But here is a really fascinating biomechanical flaw.
Okay, what is it?
The lateral margin of the frontalis attaches to the temporal ridge, and that ridge crosses the brow right at the junction of the middle and lateral thirds.
Wait, so the frontalis has absolutely zero direct muscle activity on the outer third of the brow.
Zero.
But wait, if there is no direct muscle lifting that outer edge, how is it mechanically possible for us to lift the outer tails of our eyebrows when we're surprised?
That is a great question. It's achieved through an indirect chain reaction. The frontalis doesn't pull the lateral skin directly. Instead, it pulls on the orbital portion of the orbicularis oculi muscle.
Oh, I see.
Yeah, and that orbicularis muscle has dermal connections that support the skin of the lateral brow. So the frontalis hoists the orbicularis, and the orbicularis hoists the lateral brow.
Wow, it's literally a biological pulley system.
It is, but because it relies on that indirect secondary support, it completely explains why gravity and tissue laxity devastate the outer brow first.
Right, that lack of direct muscular scaffolding is exactly why lateral brow ptosis, that outer drooping, happens years earlier than medial drooping.
Exactly. The medial brow has robust direct support. The lateral brow is relying on a secondary connection.
And while the frontalis is the solitary elevator pulling upward, it's fighting against a whole team, right?
Well, yeah. A highly coordinated team of depressor muscles actively yanking the brow downward.
The depressors are where the anatomy gets incredibly nuanced. You've got three main muscles actively fighting the frontalis.
And the primary antagonist is the corrugator supercilii,
which is a huge, high-yield topic for the board exams because it isn't just one block of tissue doing one job.
No, it has two distinct heads controlled by two entirely different nerve branches. That dual structure is vital to understand.
Right, so let's break that down. The transverse head originates from the supramedial orbital rim
and inserts into the dermis above the middle third of the eyebrow.
And its job is to pull the eyebrow medially.
Yes, that inward pulling creates those vertical globular lines, the classic 11 lines between the eyebrows.
And this transverse head is supplied by the frontal branch of cranial nerve 7.
Exactly. But then you have the oblique head.
Right, which inserts much further medially into the eyebrow skin. And it actively pulls the medial brow downward, creating oblique globular lines.
And critically, this head is supplied by the zygomatic branch of cranial nerve set.
So the corrugator's two heads are literally dividing the labor of making you look angry.
Exactly. One pulling inward, one pulling downward, powered by two separate electrical circuits.
That's wild. And then working alongside the corrugator is the depressor supercilii.
Right, which originates just below the corrugator on that supromedial orbital rim. It functions very similarly to the oblique head, depressing the medial brow.
And it is also innervated by the zygomatic branch of 7.
Yep. And then you have the final antagonist.
The procerus.
Right. It originates lower down on the nasal bones and fans out superiorly in this distinct Y shape.
And it inserts right into the inframedial edges of the frontalis and the dermis of the mid-forehead. So when the procerus fires, it yanks the medial brow down.
causing those transverse dorsal nasal lines, the horizontal wrinkles right across the bridge of your nose.
And just to make it even more complex for the exams, the FRCS has dual innervation.
It does.
Right.
From both the zygomatic and the frontal branches of the facial nerve.
So when a surgeon goes in to release that downward pull, they have to physically divide or disinsert those depressors?
But they're operating in a total minefield of sensory and motor nerves. I mean, if they cut the wrong wire, the structural release means absolutely nothing.
Right. The primary sensory wiring to protect involves the supraorbital and supratrochlear nerves.
Which branch off the ophthalmic division of the trigeminal nerve, cranial nerve V.
And the supraorbital nerve exits the orbit right in the mid-pupillary line. It immediately divides into a superficial and a deep branch.
And this bifurcation actually straddles the corrugator supercilium muscle.
Okay, so the superficial branch runs over the frontalis to supply the anterior scalp. But the deep branch, that's the one that demands intense surgical vigilance, isn't it?
Oh, absolutely. It runs deep between the periosteum and the glia before piercing the glia to provide primary sensation to the frontoparietal scalp.
And the critical danger here is its location. It runs within those glia layers, just medial to the zone of fixation.
Right. So right as the surgeon is violently prying up the nails of that densely adherent zone of fixation, they are operating mere millimeters from the primary sensory nerve of the entire upper scalp.
That is terrifying. And just medial to that, about a centimeter inward, you have the supratrochlear nerve sending 6 to 8 tiny, delicate branches right through the corrugator muscle to reach the forehead.
And the required dissection around those intricate sensory branches is exactly why temporary scalp numbness is practically a universal reality of the recovery process.
I imagine patients must experience some weird sensations as that heals.
Definitely. They'll experience significant itching and tingling as those sensory pathways attempt to regenerate months later.
But protecting sensation is only half the battle. Preserving motor function is paramount. Which brings us to the medial zygomaticotemporal vein.
Ah, the sentinel vein.
Yeah, and calling it a canary in a coal mine really doesn't do it justice, does it?
Not at all. When a surgeon encounters this vein during temporal dissection, it acts more like a tripwire.
It's a glaring neon sign warning them that the highly vulnerable frontal branches of the facial nerve are basically right next to it.
Right. The very wiring that allows the patient to lift their eyebrows at all. Transient injury to that frontal branch is a known risk. And it can take weeks for a patient to recover their ability to raise their brow.
And what other complications do you have to counsel patients on?
Well, asymmetry, obviously, hematoma, and alopecia.
Alopecia usually occurs if the surgeon fails to adequately release those deep fascial layers, right?
Exactly, because then they end up relying on the skin closure to hold the tension of the lift, and that tension destroys the hair follicles.
Okay, so with the complex anatomy mapped, the nails pried up, the muscles identified, and the nerves protected, the surgeon has a fully mobilized forehead.
But where does it actually belong?
Right. The blueprint for resetting the human expression relies on Ellen Bogen's 5 criteria.
And this isn't just an aesthetic guideline. It is a precise geometric blueprint for the ideal eyebrow position. Highly testable for the boards.
Extremely testable. So let's list them. First, the medial edge of the brow should begin at a vertical line drawn straight up from the ipsilateral alar base of the nose.
Passing right through the medial canthus of the eye.
Right. Second, the lateral tail of the brow should end at an oblique line drawn from that same alar base through the lateral canthus.
Perfect. Third, the medial and lateral ends of the brow should rest on the exact same horizontal plane.
Got it. Fourth, the apex, the absolute highest point of the arch, must align perfectly above the lateral limbus.
Which is the outer edge of the colored iris for those visualizing it.
And fifth, you have to factor in the distinct gender differences in skeletal anatomy.
Right. For women, the ideal brow arches distinctly above the supraorbital rim. But for men, the brow should rest flatter, approximately at the level of the bony rim itself.
You know, what's truly fascinating is that patients rarely walk into a clinic asking to have their brow apex realigned with their lateral limbus.
No, they never see that.
The clinical history reveals this deep blurring between aesthetic desire and functional necessity.
Because of the tissue drooping, these patients are unintentionally broadcasting negative emotions.
Exactly. A heavy descended brow mechanically forces the face into an expression that looks perpetually exhausted, deeply sad, or intensely angry, regardless of their actual mood.
And the functional burden is just as significant.
How so?
Well, because the tissue is resting heavily on the upper eyelids and obstructing their visual field, the frontalis muscle is forced into a state of constant all-day contraction.
Just to pull the skin out of the way so they can see.
Right. And that relentless muscle exhaustion translates directly into chronic physical tension headaches.
Wow. So the surgery isn't just about restoring youth. It is fundamentally about resetting the resting emotional baseline and curing physical fatigue.
Absolutely.
And to achieve that, surgeons rely on three primary techniques, right? The coronal, the endoscopic, and the transpalpebral approaches.
Yes. And prior to any incisions, the patient is marked upright, highlighting the glabellar lines and the exact vector of elevation.
Pushing superlaterally from the brow apex.
Right. So let's start with the coronal technique. This is the historical gold standard.
It involves a massive incision, doesn't it?
Huge, spanning 7 to 9 centimeters posterior to the frontal hairline.
Ouch.
Yeah, and from there, the surgeon literally peels the entire forehead flap forward over the frontal bone.
Dissecting in either the subgaleal or superiosteal plane.
Exactly. And over the temporal fossa, they dissect between the superficial and deep temporal fasciae.
So once that massive flap is fully reflected forward, they basically have direct, wide-open access to visually identify and divide the glabular depressor muscles.
Yes. And then they physically grab that entire mobilized scalp, pull it backward under extreme tension to elevate the brows.
Cut away the overlapping strip of excess scalp and suture it closed.
It is a highly invasive approach, and it is rapidly waning in popularity.
I can see why. The complication profile of the coronal approach is severe.
It really is. You are creating a massive scar across the scalp. The risk of permanent scalp numbness is high because you are cutting across so many sensory nerve pathways.
Not to mention the significant risk of alopecia from all that tension.
But crucially, pulling that enormous flap backward mechanically raises the patient's frontal hairline.
Exposing far more forehead, which is often an aesthetically terrible outcome for the patient.
Right. So the modern evolution of this is the endoscopic technique, or the endobrow.
Instead of a massive incision, the surgeon makes 5 precise, small incisions hidden within the hairline.
You have 3 in the anterior frontal scalp, 1 in the midline, 2 lateral aligned perfectly with the planned vector of elevation.
And dissection goes straight down to the bone, continuing superiosteally.
Then 2 more incisions are placed laterally in the temporal areas, deepen down to the deep temporal fascia.
So they insert an endoscope to visualize the anatomy on a monitor.
Yes, and this magnification allows for an incredibly delicate, precise release of those dangerous zones of adherence we talked about.
Get the superior temporal fusion line and the supraorbital rim.
Exactly. All while actively protecting the deep branches of the sensory nerves. They divide the periosteum at the rim, which drops the tissue and exposes the corrugator and procerus muscles.
So they can be carefully divided using endoscopic instruments.
Yes.
And this is what really struck me, because this method doesn't rely on cutting away massive strips of excess scalp to pull the face tight. The fixation strategy is intense.
Oh, it's literal carpentry.
Right. You are looking at heavy-duty orthopedic carpentry for forehead skin. We're talking about drilling bone tunnels, embedding Metec bone anchors
Driving unicortical titanium screws into the outer table of the skull.
to support skin staples, or using bioabsorbable endotine devices with multiple tines to grab the tissue. Why do we need literal titanium screws just to hold up forehead skin?
It goes back to tissue memory and gravity. Remember, you have thoroughly unnailed the carpet, you have severed the depressor muscles.
The tissue is completely free.
Completely free. So if you simply close the skin incisions, the sheer weight of the tissue will instantly drag the brow right back down to where it started. The entire mobilized flap must be rigidly bolted to the skull to hold it against the forces of gravity while the deep tissues heal.
And form new, permanent, elevated adhesions.
Exactly. Additionally, the superficial temporal fascia in the flap is securely sutured to the immobile, deep temporal fascia to lock the lateral brow in place.
It really is about resetting the foundation rather than just stretching the roof.
Perfectly said.
So the third option is the transpalpebral approach. This circumvents the scalp entirely, right?
It does. The surgeon goes in from below, utilizing a standard upper eyelid incision, basically an upper blepharoplasty approach.
And they dissect upward over the orbital rim and into the supraorbital subgaleal plane.
Right, and from that eyelid incision, the surgeon can elevate the entire lateral brow complex along with the orbicularis oculi muscle.
And the medial aspect of that same incision provides direct access to the corrugator and depressor supercilii muscles from below.
Allowing them to be divided. The elevated brow tissue is then anchored to the lateral brow periosteum using sutures or a specialized endotine device.
The transpalpebral approach seems like an incredibly elegant solution for balding men.
Oh, it is, because it completely eliminates the risk of a visible hairline scar.
And it is also excellent for patients with only mild brow ptosis. However,
There's a catch.
yeah, because you cannot access or elevate the entire broad expanse of the frontalis muscle from that small lower window, this technique completely fails to address deep transverse forehead lines.
Exactly. The choice of technique really requires matching the mechanical limitations of the surgery to the specific anatomical deficit of the patient.
Masterful. Mastering how the fascial layers, the muscular tug-of-war, and the nerve pathways interact is basically the only way to succeed in the operating room.
And it is exactly what your board examiners are looking for.
Which brings up a really profound final thought regarding the intersection of anatomy and psychology.
Okay, what are you thinking?
Well, we know that severe brow ptosis forces a patient into an expression of unintentional anger, right?
Right.
And the constant frontalis contraction required to fight that drooping causes debilitating physical headaches.
Yes, the tension is immense.
So if our facial muscles are locked in this heavy, relentless physical tug of war that dictates our perceived mood to the outside world,
Mm-hmm.
how much of our own internal emotional state is actually being driven by the physical heavy weight of our own anatomy?
Oh, that's fascinating.
Right. Does a tired, heavy, mechanically drooping brow actually make a person feel more physically exhausted on a neurological level?
It really highlights a fascinating feedback loop. Our anatomy doesn't just display our emotions. The mechanical strain of that anatomy actively shapes our psychological and physical well-being.
Exactly. So to our listeners, as you go about your clinical rounds, take a moment to really observe the mechanics of expression in the faces around you.
Look past the skin and visualize the corrugator pulling medially, the frontalis fighting upward.
In the fascial anchors holding it all together. If this breakdown helped clarify the tissue planes for your upcoming exams, please press follow on the show and leave a comment or question about which anatomical tripwire surprised you the most today. Good luck with your studies and keep diving deep.